Why counting backwards is just a party trick. If you've ever been told to count backward from 10 as anesthesia begins, you might think that's how consciousness gets switched off. The reality is that the numbers aren't doing anything to your brain at all. That counting is just a small distraction, something simple for you to focus on in the last clear moments before the drugs take effect. The real shift comes not from reaching zero, but from the chemistry already moving through your system. In modern practice, induction of anesthesia happens fast. If you're given an intravenous drug like propofol, it typically takes effect within seconds to under a minute. By the time you've spoken a few numbers, molecules are already binding to key receptors in your nervous system and slowing them down. With mask-based inhalation, the timeline stretches a little longer. The gases need a couple of minutes to build up to effective levels in your brain. Either way, the transition has very little to do with finishing a countdown. A lot of people who go under don't even remember starting to count. That's because anesthetics interfere with the hippocampus almost immediately, disrupting the circuits that encode short-term events into memory. From your perspective, it feels like the moment simply vanishes. You may recall a nurse asking you to begin, but the next thing you know, it's later in the recovery room. Memory does not gracefully fade, it simply stops recording. So what's happening beneath the surface? The simplest explanation is that anesthetic drugs change how brain cells communicate. Some IV medications enhance inhibitory GABA activity, while others block excitatory NMDA signaling. Both affects quiet neural conversations, reducing the ability of networks to synchronize in the way consciousness depends on. A useful way to think of it is like traffic lights across a city suddenly switching to red at the same time. Cars remain on the road, but no one can go anywhere. Mental traffic stalls and awareness disappears. This quirk also explains why a clever line rehearsed beforehand almost never survives into memory. Plenty of patients plan something funny to say before they go under, but the drugs get ahead of them. As soon as the hippocampus shuts down, sentences trail off or never get stored. Anything said in those moments is usually forgotten, which is why people often debate later what the last words really were. In most cases, there was nothing coherent enough to remember. Even though counting doesn't cause loss of consciousness, the ritual has stuck around. Historically, before fast-acting agents were available, it gave anesthesiologists a rough gauge of how quickly sedation was progressing. Today, its function is mainly psychological. Repeating numbers provides a simple focus for patients, especially children, and helps take the edge off anxiety. That's not trivial. Stress itself ramps up heart rate and adrenaline, and a repetitive task can ease that sympathetic surge. For the anesthesiologist, those spoken numbers can still offer useful feedback. A child who suddenly stops mid-sequence signals the exact moment a drug begins working. Even adults sometimes trail off mid-sentence because the shutdown is so abrupt. One instant you're speaking normally, the next there's silence. To outside observers, this is routine, but for the patient, there's no recollection because the process disconnects awareness rather than allowing time for reflection. From the inside, this process is stranger still. The human brain can't register the steps of its own shutdown. We expect to feel ourselves slipping away, but that expectation comes from experiences like falling asleep. With anesthesia, one moment is ordinary and the next is gone, with no sensation of the transition. Whether you're halfway through a sentence or a number, awareness ends before you can notice it. It's worth addressing one fear that sometimes surfaces: the rare reports of people waking during surgery but unable to move. This phenomenon, called intraoperative awareness with paralysis, is real but exceptionally uncommon in modern practice. Careful dosing, continuous monitoring of multiple physiological signs, and use of drugs that combine unconsciousness with amnesia mean that the overwhelming majority of patients never experience anything like it. For trained providers, preventing awareness is a critical part of the process. The speed and efficiency of induction often surprise patients. Some imagine a gradual descent into unconsciousness, like drifting off in a darkened room. Instead, anesthesia is more abrupt, a sharp cut in the timeline. One moment you're present, the next it's hours later, with no perception of what bridged the gap. Hollywood's drawn-out countdown scenes make for drama, but they misrepresent the immediacy of the shift. By the time the drugs reach their targets, multiple layers of function are silenced in rapid succession. Circuits that support consciousness lose integration, memory encoding networks are disabled, and pain signals are suppressed before they reach awareness. The end result is not a slow merger into sleep, but a precise, engineered blackout. The counting, then, is just a courtesy gesture, something human and familiar at the very edge of awareness. Understanding that anesthesia acts so quickly helps put some common worries into perspective. People often imagine that saying something embarrassing will haunt them later, but in truth, there's almost no chance their words were stored in memory or even completed. The real unknown isn't what you might blurt out. It's the remarkable biology guiding that instantaneous leap from full wakefulness to blackout. And it's this same process that feeds into a much bigger worry many people have yet to shake. Not what might happen during those blanked-out minutes, but what happens on the other end of them. Once the drugs have switched everything off so completely, some can't help but ask what guarantees they'll wake up again. That lingering anxiety leads directly to one of the most common questions patients still bring into the operating room. The 2025 safety numbers nobody expects. What often catches people off guard is just how safe anesthesia has become in 2025. While many patients imagine the worst when they think about going under, the actual numbers tell a very different story. The most reliable modern data show that deaths attributable solely to anesthesia itself now fall in the range of roughly 1 in 100,000 to 1 in 300,000 anesthetics for otherwise healthy patients. For context, the Anesthesia Patient Safety Foundation consistently reports that mortality today is dramatically lower than what was seen a generation or two ago. In plain terms, the risk is far smaller than everyday hazards most of us accept without thought, such as the drive to the hospital. That improvement isn't by chance. It arises from decades of systematic changes. In the mid-20th century, anesthesia complications were far more common, often because the available drugs were long-acting or unpredictable, and because airway problems or hidden medical issues could spiral quickly into crisis. Modern anesthesia relies on short-acting agents that wear off quickly when the infusion stops, advanced airway tools that make maintaining breathing far safer, and standardized monitoring that every anesthesiologist must use by mandate. Pulse oximetry to track oxygen, capnography to track exhaled carbon dioxide, continuous ECG, automated blood pressure, and temperature probes are part of the minimum standard almost universally. Those monitors, combined with mandatory checklists and regular simulation training, have pushed anesthesia safety into a realm few thought possible decades ago. This progress is why anesthesia complications that were once a genuine risk now stand out as outliers. Most of what patients experience after routine anesthesia falls into the category of minor annoyances rather than life-threatening events. Nausea, grogginess, sore throat from a breathing tube, or muscle aches from certain medications are far more common than any serious emergency. They may be unpleasant for a few hours, but they are not dangerous and usually clear quickly. That reality contrasts sharply with the lingering fear of never waking up, which for the overwhelming majority of patients is statistically vanishingly small. Another factor patients may not always recognize is the role of training. Anesthesiologists undergo years of advanced medical education after medical school, residency, board examinations, and ongoing certification, focused specifically on anticipating and managing both ordinary and rare complications. They rehearse scenarios that most will never encounter in a real case, because preparation is the safeguard. On top of that, high-fidelity simulators and standardized crisis protocols allow providers to act decisively even in situations that arise once in a career. Just like aviation, where pilots train for emergencies they may never see, anesthesia emphasizes preparedness for every outcome. In turn, redundancy across drugs, monitors, and emergency equipment ensures that no single failure quickly leads to catastrophe. Safety also benefits from a cultural shift in medicine over the past several decades. The operating room today is designed for team communication where every person, from anesthesiologist to circulating nurse, is encouraged to point out concerns early. Checklists are applied before every induction, much like a pre-flight procedure, confirming correct drugs, available reversal agents, and patient-specific details. This standardization matters. It minimizes human error, which historically was one of the main contributors to anesthesia mishaps. Even with all those systems in place, the biggest guarantee of safety often comes from tailoring the anesthetic plan to the individual person. In the past, dosing guidelines leaned heavily on weight and general estimates. By 2025, anesthesiology has shifted toward more personalized strategies. Patient age, cardiovascular health, Pulmonary status, obesity, presence of sleep apnea, kidney or liver function, and even response patterns tracked through electronic health records all shape what drugs are chosen and at what doses. Machine learning models are increasingly assisting anesthesiologists in predicting which patients might benefit from specific airway tools or adjusted induction techniques. The aim is not only comfort, but precision that avoids both under- and overdosing while keeping vital functions stable. From the patient's perspective, this translates to reassurance but also responsibility. While the general risk in 2025 remains exceptionally low, individual medical conditions still matter. That's why the pre-anesthesia consultation is not just a formality. Talking openly with your anesthesiologist about factors such as asthma, heart disease, sleep apnea, diabetes, smoking, or even regular use of over-the-counter supplements gives them the information needed to fine-tune the plan. For viewers, this is the single most practical step you can take. Be transparent in pre-op discussions so your anesthesiologist can anticipate potential difficulties long before induction begins. When framed this way, the safety of anesthesia becomes less abstract. Instead of thinking of it as handing over the keys to your consciousness with no guarantees, it helps to view it as entering a system built on redundancy, constant surveillance, and individualized planning. The nightmare scenarios people imagined made sense when monitoring was crude and drug options were blunt tools. Today, most anesthetics proceed uneventfully, and the rare emergencies that do occur are typically recognized and managed before harm results. Also striking to compare what the data suggests now versus half a century ago. In the 1940s and 50s, anesthesia-related mortality was measured in the range of 1 in 1,500 to 1 in 10,000. That meant every anesthesiologist could expect to witness multiple serious events across a career. Fast forward to today's 1 in 100,000 to 1 in 300,000 for healthy cases, and you see how drastically the environment has changed. The shift stems not from a single breakthrough, but from the steady layering of small, systematic improvements, monitor alarms, shorter half-life drugs, shoulder-to-shoulder collaboration. Each advancement narrowed the margin for error until modern anesthesia began to look less like high-stakes gambling and more like controlled precision. Still, numbers alone don't completely soothe the unease. There's a psychological gap between understanding something is safe and feeling that safety in your bones. Few people get nervous stepping into their car, even though the actuarial odds are worse. Yet lying on an operating table, surrounded by unfamiliar machines, taps into a primal fear, the inability to steer your own body. What helps close that gap is reframing what's happening. You're not abandoned during unconsciousness. You're monitored in ways that exceed everyday experience. Every breath, every heartbeat, every shift in brain activity is tracked, interpreted, and adjusted for continuously. The irony of all this is that one of the most intimidating aspects of surgery is in fact the safest. Procedures themselves carry uncertainty depending on the site, the disease, and the repair. But the anesthesia that makes operations possible is designed to insulate you from pain, stress, and trauma. The field's relentless emphasis on analysis after every rare incident ensures that safety only grows stronger over time. When you step away from the fear and look at the system as it operates today, the bigger question is, will I ever wake up? But rather, how exactly does anesthesia shut down the brain without shutting down the whole person? And that question leads directly into the surprising way anesthetics actually interact with the brain's networks, which is far more complex than flipping a single on-off switch. The brain shutdown isn't all or nothing. Most people imagine that anesthesia sweeps over the brain like someone pulling a master switch. One moment there's full awareness, and the next there's nothing, an instant blackout. It's a simple image, shaped by movies and old explanations, but it's not what actually happens. Instead, anesthesia is more like closing down apps on a device, one program at a time. Memory, awareness, movement, and pain each power down in a sequence, carefully managed by drugs designed to target different receptors. The system never shuts off completely. Basic life functions remain running while the conscious parts are suspended. That phone app view helps clarify what's really going on. No matter how many apps you close, the phone itself is still on, still maintaining core processes. In anesthesia, the vital systems that govern circulation, temperature regulation, and reflex survival functions continue to operate. What gets suppressed are the higher programs, the complex networks that create the experience of consciousness. Which app closes first depends on the drugs chosen. Some agents act fast on the hippocampus, where memory formation takes place. Others target GABA or NMDA receptors, quieting the cortex and disrupting the synchronized communication needed for awareness. Opioids, often added to the mix, work on opioid receptors to block pain signaling before it ever reaches full perception. Clinically, once those drugs reach effective concentrations, resistance is not meaningful. It's a biochemical effect that overrides voluntary effort, but one that fully reverses as the drugs wear off. Memory almost always goes down first. Patients may still be talking, but their brain isn't filing new information away. From their perspective, time simply jumps forward. Next, the sense of awareness dissolves as cortical networks lose the ability to coordinate activity across brain regions. The orchestra of neurons is still playing, but without synchronization, there's no experience of the music. At that point, consciousness is absent no matter what the body may look like from the outside. Movement and reflexes come after. If anesthesia only erased awareness, the body could still twitch or resist surgical stimulation, which would make operations dangerous. To prevent this, anesthetics depress the spinal cord's motor pathways, and in many cases, neuromuscular blockers are added to guarantee immobility. These drugs don't operate on memory or awareness at all. They work peripherally, silencing the skeletal muscles. It ensures that even reflex responses never reach the surface. The process is not one of feeling and failing to move. It's simply the absence of that motor communication altogether. Pain control closes the loop. Pain is always the product of signals climbing from peripheral nerves to the spinal cord and on up to cortical centers. General anesthesia blocks that pathway at multiple levels. Opioids intercept the messages at the receptor. Inhaled and intravenous agents suppress spinal transmission. Sedatives dull the brain's response at the top of the chain. The signals themselves may continue firing in the nerves, but they arrive at no functional destination. In effect, the pain app is closed, and there's no conscious system left to notice unfelt messages. This layering explains why wake-up doesn't feel symmetrical to going under. As drugs wear off, not every system resurfaces at the same pace. Reflexes may return first, so you can move before your mind is fully aware. Memory can lag, so you may already be awake before you start recording new experiences. Awareness often feels like it dawns abruptly, producing that uncanny break where the next moment you recognize, you're already in the recovery unit. Just as the shutdown is staggered, the reboot process comes back online in steps, because these transitions involve different receptor systems. GABA for sedation, NMDA for blocking excitation, opioid receptors for pain, and neuromuscular junctions for movement. It's possible to fine-tune the balance. An anesthesiologist can emphasize stronger pain control while keeping sedative levels lighter, as in some obstetric cases, or induce deep unconsciousness paired with full muscle relaxation for more invasive surgery. The sequence is flexible, and while memory and awareness usually go early, the order of other changes depends on the combination used. Another important distinction is what stays active throughout. The autonomic centers in the brainstem that regulate heartbeat and basic breathing rhythms remain intact. Under controlled conditions, ventilation is often supported and monitored, but those core circuits never fully turn off. That's why anesthesia is not like removing the battery from a device. It's like suspending every optional program but leaving the operating system running. From a patient's point of view, the result is an instant blackout. But from the neurobiological side, it's a sequence of silenced functions linked to measured concentrations of drugs in the body. This is why induction is so reliable and recovery just as predictable. The shutdown is not driven by will, fatigue, or psychology. It's chemistry acting precisely at receptor sites. When the infusion stops or the gases wash out, those effects fade and the system reassembles itself. Framing it this way also helps explain why anesthesia is safe even though it seems mysterious. Nothing is erased or permanently damaged. The functions you rely on to feel, move, and remember are only placed in suspension. Once the drugs leave your system, those circuits resume activity as if they were paused. It's that reversible character, selective inhibition without destruction, that defines modern anesthesia. Misunderstanding it as a total blackout adds unnecessary fear. The truth is that your brain under anesthesia is active, just not integrated in the way necessary for experience. Each component, memory, awareness, movement, and pain, is muted in its own window of time, sometimes overlapping, sometimes staggered, but collectively producing the seamless gap you perceive. By staging this shutdown in layers, anesthesiologists create the illusion of instant disappearance while keeping the essential background running. And while that illusion has often been compared to sleep, it is not the same. Sleep restores networks, rotates through cycles, and maintains rhythms designed for recovery. Anesthesia, by contrast, disables connections instead of nurturing them. To an observer, the unconsciousness may resemble slumber, but the brainwaves tell a very different story. That difference, and why it matters, is the next crucial piece of understanding. The real science behind the sleep that isn't sleep. Every patient has heard the same phrase before surgery. Someone leans close and says, "We'll put you to sleep." It's meant to calm nerves, but scientifically it isn't accurate. Anesthesia is not sleep. It only seems like it because you enter a gap in awareness. Real sleep is an active biological process with repeating cycles, while anesthesia is a pharmacologically induced, reversible state that suspends consciousness without restoring or repairing the brain. Understanding why that distinction matters requires looking closely at what each state actually does. During natural sleep, your brain moves through structured stages in predictable cycles. Non-REM phases support tissue repair and general recovery, while REM phases are critical for processing emotions and consolidating experiences into memory. EEG recordings show recognizable rhythms, the constant rise and fall of brainwave frequencies that mark healthy rest. Even though you're unaware of the outside world, your brain remains active, building connections, pruning unnecessary ones, and replaying patterns that encode learning. That is why good sleep leaves you refreshed, stabilized in mood, and sharper in cognition. Anesthesia shows none of these features. Under general anesthesia, large-scale brain networks lose the ability to communicate with one another. Instead of rhythmic cycling, activity either flattens into slow, disrupted patterns or breaks into bursts unrelated to normal sleep physiology. Functional MRI and EEG evidence confirm these differences. Areas of the cortex that usually coordinate with the thalamus fail to link, and the normal balance of phase-locked brainwaves disappear. Put simply, anesthesia doesn't let the brain work, it pulls the plug on network integration. The brain doesn't process memories, it doesn't regulate itself through cycles, and it doesn't come out stronger on the other side. This explains why anesthesia does not serve restorative purposes. Sleep deprivation triggers recovery periods. Miss a night and your body drives you into longer, deeper stages the next evening. After anesthesia, no rebound occurs. There's no prolonged REM, no catch-up, slow wave deepening, because the brain doesn't interpret anesthesia as sleep at all. You were disconnected, not repaired. The haziness and disorientation people feel upon waking is not grogginess from oversleep. It reflects the chemistry wearing off and networks struggling to resynchronize after being held apart. One of the clearest functional differences lies in memory. During sleep, the hippocampus actively replays daily experiences, transferring them into long-term storage. Under anesthesia, the hippocampus stops encoding almost immediately. That's why most patients recall nothing from the operating room, even if they were technically conscious for a few early instants. The blackout isn't passive forgetting. It's the inability of the memory system to write anything down in the first place. Sleep enhances memory consolidation. Anesthesia halts it outright. So why doesn't that disruption damage the brain permanently? The answer is reversibility. Anesthetic drugs alter receptor activity in ways that prevent large-scale coordination, but only for as long as the drugs are present. Once levels fall, the networks can reconnect. Unlike chronic sleep deprivation, which accumulates biological harm, anesthetic exposure ends cleanly. It suspends cognitive function for hours, but because it is carefully controlled, the effects fade predictably with metabolism. That's why anesthesia can be repeated safely across millions of surgeries worldwide. In practice, this distinction shows up after operations. Even after a long nap under anesthesia, patients don't wake with the same clarity and energy that follow true sleep. Instead, they may feel foggy, clumsy, or temporarily confused. Studies using EEG show that the brain doesn't immediately snap back into coordinated rhythms. Different regions reconnect at slightly different rates, creating a staggered return to normal consciousness. What patients describe as coming out of a fog reflects those uneven reconnections more than any restful state. For anesthesiologists, these differences matter clinically. Modern monitoring doesn't treat anesthesia as stages of sleep, but as measurable levels of disconnection. Devices that process EEG now produce simplified depth of anesthesia indices. These numbers don't grade how deeply asleep you are, they reflect how reduced your brain's connectivity has become. External stimulation during natural sleep might rouse you with a sharp sound. Under anesthesia, the same sound fails to reach conscious perception because the networks that would pass the signal forward are offline. Information reaches sensory nerves but stops there, never assembling into experience. A useful way to appreciate the contrast is by thinking about outcomes. Sleep is essential for survival. Without it, immune function declines, mood collapses, and memory fails. Anesthesia provides none of those benefits. Its purpose is utilitarian, to erase awareness, immobilize the body, and block pain during surgery. You leave the operating room alive and unharmed by the procedure, something impossible without anesthesia. But you don't leave more rested, restored, or sharper than before. The healing that happens afterward comes from the surgery and from the return to natural sleep in recovery, not from the anesthetic itself. Research from Harvard, MIT, and other neuroscience centers in recent years has emphasized this point with striking imaging evidence. Sleep shows cycles of synchronized slow waves and bursts, while anesthesia strips those cycles away, replacing them with flattened signals or abnormal oscillations that never rotate through healthy phases. The bottom line is simple. Anesthesia is not an evolutionary rest state, but a pharmacological suspension. The two may feel similar only because both involve missing a stretch of time. Biologically, they are worlds apart. This understanding also helps explain why the language of putting you to sleep persists. It's easier to say, and it reduces anxiety before surgery, even if it misleads. Patients rarely want to hear, "We're about to induce a chemical state that shuts down awareness of everything," even though that's the truer description. For reassurance, the term sleep sticks, but it hides the fact that no one is guiding you through dream cycles or natural rest. What's happening is engineered silence, not nurturing restoration. So the best way to think of anesthesia is as a controllable blackout. It is reversible, predictable, and medically useful. It is not something your brain enters voluntarily or something you can practice on your own. It is induced, sustained, and terminated entirely by drugs designed for precision. Understanding this clears up one of the biggest misconceptions patients carry in. Anesthesia may feel like drifting off to sleep, but it is not. It is an absence, a void in function with no parallel in your daily biology. And that distinction leads to an important takeaway. Don't expect anesthesia to give you the benefits of real sleep. It does not restore, it does not help cognition, and it does not build memory. What it does is block awareness long enough for surgeons to work safely and for you to avoid trauma. It's not sleep, it's a tool, and a powerful one. A tool that only works because someone is keeping it tightly controlled from start to finish.